Welcome to this week's Echo Diabetes in a Time of COVID-19 webinar session. I'm Dr. Nick Cuttress, Program Director and Pediatric Endocrinologist at Stanford University. Good morning, good afternoon, good evening, depending where you're joining us from. Thank you for being a champion for people living with diabetes. We're grateful for the unrestricted educational grants that we received from Novo Nordisk and Pfizer Inc. that make this program possible. Our goal is to address the urgent needs of patients with type 1 and type 2 diabetes who require complex diabetes treatment in the time of COVID-19 and beyond. We want to empower primary care providers and clinics to safely and effectively manage underserved patients who do not have access to routine specialty diabetes care. Even before COVID-19 pandemic, outcomes for patients with diabetes were suboptimal. We must recognize that poor outcomes for people with diabetes on a population level does not reflect patient, quote, non-compliance, but rather system failure. And we as providers in a health system must change our approach to focusing on diabetes outcomes and costs. Data from 191 million people enrolled in health plans that report HEDIS results to the National Committee on Quality Assurance illustrates system failure for patients with diabetes. In 2018, less than 1/3 of patients with type 1 and type 2 diabetes had A1C values at target or less than 7%. Even more concerning, as demonstrated here on this slide, 30 to 40% of patients with type 1 and type 2 diabetes had A1C values greater than 9%. Minimizing hyperglycemia is paramount to reducing diabetes patient risks and vulnerability to infection and complications, including COVID-19. Now is an opportune time to overcome therapeutic inertia and make meaningful system changes so that patients are being able to achieve glycemic targets. We are living in unprecedented times with COVID-19, but systemic racism and health inequalities have been endemic to the U.S. COVID-19 is making these injustices more clear. We must come together as a medical community and change our practice. We must act. When the mortality rate from COVID-19 in Black Americans is at least twice, if not 5 times as high as the mortality rate from whites, we must act. When marked racial disparities in diabetes management exists, and prior to COVID-19, we must act. When Black Americans with diabetes with equivalent socioeconomic status as white Americans are less likely to be prescribed intensive insulin management regimens, newer medications, diabetes technologies proven to improve diabetes outcomes, we must act. We must act and recognize systemic racism and implicit bias that are also occurring within our medical community and practice today. Our leadership team and faculty are committed to promoting health equity through our program and combating systemic racism in the U.S. We're committed to action. Here at Stanford, we're partnering with Project ECHO and other sites across the United States on this series. Project ECHO is a globally recognized hub and spoke outreach model developed at the University of New Mexico to reduce disparities and improve health outcomes in patients who otherwise lack routine specialty care. Zoom-based clinics led by multidisciplinary faculty from academic medical centers and community organizations provide community providers with education, case-based learning, and expertise they need to treat patients within their own community. We have an exciting series of presentations, all of which made available on-demand sessions after their live presentation. You can access these on-demand sessions on our website, diabetescovid.stanford.edu. You can also access information on our live webinars, patient and provider diabetes and COVID resources, and soon to come an FAQ with answers to questions asked during the webinars, as well as the questions submitted during the live webinar registration process. For our on-demand session, we'll address the high-impact follow-up questions from our last session, a lecture, and we will then address pre-submitted questions from an audience member, submitting questions during the registration for our live webinar. Our case presentations are not available for the on-demand webinar. We're fortunate to have a national faculty from over 12 ECHO programs and organizations around the country. And we'll now move on to our high-impact questions for the week.
Question was, how can motivational interviewing be used via telehealth to shape habits of people with diabetes in the midst of the pandemic?
Okay, thanks, Nick. So I will go through these briefly. So the questions that were submitted were, number one, experience with motivational interviewing and change talk methods to engage patients, and I'll give a brief review. Number two, how to shape the habits of patients with diabetes in the midst of a pandemic. And we're gonna propose that through the use of motivational interviewing to do that. And then another question was how to do motivational interviewing via telehealth versus face-to-face. So if you will click next, I'm going to give you some ideas and tips, but I first wanted to say, let's just review what is motivational interviewing. It is defined as a collaborative conversation style for strengthening a person's own motivation and commitment to change. Next. And keep clicking. There we go. So the underlying spirit is what's known as evocation. So in healthcare and as healthcare providers, we often have a sense of, well, I'm the expert and I know what is best for you and I'm going to tell it to you and you are going to use my knowledge and wisdom to change these ways to become healthier. Well, that often doesn't work when we are trying to help people make some personal changes and change their behaviors. So the message underlying motivational interviewing is really that you, the patient, you have what you need to change your behaviors, and then together we're going to find what that is. So we're going to help evoke and call forth the strengths that people have within them to change. It involves establishing a partnership and working in collaboration with the patient and actively promoting that patient's welfare, but also acknowledging that that patient has autonomy. And you must ask for their permission to help them make these changes. So the four processes of motivational interviewing are working together, but if you will click, there we go. So we have engaging, which is establishing rapport or working alliance. Focusing, it's the process of developing one or more clear goals for change. Evoking, calling forth the patient's own motivations for and ideas about change. And then planning, which is the collaborative development of the next steps that the patient is willing to take. So if you'll click next. So as you are engaging in the process of motivational interviewing, listen for change talk. They are verbal expressions of the patient's readiness to change. If you'll click next. So one way to do this are to ask open questions that the patients are likely to answer with change talk. So for example, what do you hope for your own health in the future? And that would communicate desire. What one step might you be able to take to control your blood sugar better? Would indicate ability. And then what would you say are 3 good reasons to manage your diabetes well? And that would be reasons. And then what do you think you need to do at this point? Might be need. Next. So one of the ways to help folks when they can come up with, well, what do I need to do, is to help them construct a change plan. And one way to do this is through the use of setting SMART goals. So SMART stands for specific, measurable, attainable, realistic, and timely. So basically try to, rather than saying, I want to exercise more, make that very specific, but also focusing on what does the patient want to do. If they say they want to exercise more, help them narrow it down. For example, I will walk 3 miles per day. Measurables should be very clear methods for gauging their progress and success. Should be challenging, but within a person's ability to achieve, realistic based on their current status, and timely, a set time frame for goal achievement. Use of this SMART goal strategy can be very helpful during a pandemic, because you can really think about, okay, what are my limitations, what is realistic, what is attainable, and have the patient collaborate in this process to set these goals. Next. So I have found doing motivational interviewing via telemedicine has some, pluses and minuses. But one way you can do that is to remember these foundations of motivational interviewing and really apply them in your telemedicine visits. So ask open questions, elicit change talk. Remember that silence is okay. It's awkward, but it's okay. Help them identify their SMART goals. It can be useful to type up the plan. If you have the ability to share your screen with your patients when doing telemedicine, that is great to help them visualize their goals. After the visit, email the written plan and then follow up with them soon, even if it's a quick 20-minute telemedicine visit, to go over those. Next, please. And then one of the positive things I found with telemedicine was actually the ability to see folks in their environment. So for example, if the patient chooses a goal to change their eating behaviors, you can have them show you their pantry and their refrigerator. You can look at nutrition labels, what are the portion sizes, help them identify ways to change their eating to more healthy behaviors. If they want to work on taking medications more consistently, have them show where they keep their medications and supplies. If they say, I don't have any place to exercise, well, have them show you their home surroundings, and perhaps even the couch could be a great place to do some exercises. So there is some evidence that was recently shared at the Association of Diabetes Care and Education Specialists Conference earlier this month. The researchers presented a systematic review evaluating outcomes of motivational interviewing via telehealth to people with diabetes. And they found, if you will click next, that almost all, 14 out of 15, reported statistically significant impact of MI delivered via telehealth. So if you are not already using it, please give it a try. Next slide. And motivationalinterviewing.org is a fantastic resource, and you can actually do online trainings and learn more. There is actually a book, Motivational Interviewing and Diabetes Care, that's also a great resource. Thanks for the time.
Thanks so much for sharing that, Eleni. Now we're going to move on to our didactic presentation, and I want to introduce Eileen Egan. Eileen serves as Director of Diabetes Education for the faculty practice at NYU Winthrop University Hospital. Her responsibilities include direct patient care, staff education, serving as a preceptor for nurse practitioner students, as well as mentoring fellows and residents. Eileen works extensively with new emerging diabetes technologies, as well as transitioning young adults from the pediatric to adult diabetes team. She speaks nationally to healthcare professionals of all disciplines regarding diabetes. She's actively involved in research as a principal investigator and sub-investigator. She serves as reviewers for journals, textbooks, and conference abstracts. Eileen was named the 2012 New York Metropolitan Diabetes Education of the Year and 2018 Nurse Practitioner of the Year for the Nurse Practitioner Association of Long Island. Eileen is a fellow of the Association of Diabetes Care and Education Specialists. Thank you so much, Eileen, for joining us. And I'm going to stop sharing my screen. We'll just pause a moment for Eileen to bring up her screen.
Okay. Thank you, everybody, for joining me today. Thank you for having me at this ECHO presentation. I'm transmitting to you from New York today. And like many of you in different areas of the country, we were hit very hard by COVID. And we were, as in our endocrine practice and serving our patients with diabetes, really tasked with pivoting quickly and transitioning our care to 100% remote and virtual visits in order to not allow for gaps in our patient care and to help our patients continue with success with their diabetes virtually and remotely. I have no disclosures, and your learning objectives are listed for you here. So your patient's on insulin and a pandemic hits the country. What now? So we really want to keep the pendulum moving. If you've been successful in getting your patient on insulin therapy, we want to avoid inertia and keep progress happening. We want to help our patients achieve their personal goals remotely and face-to-face, and certainly we want to maintain safety. We know insulin can cause hypoglycemia. So in order to do this, we need to provide ongoing education and support. Does this sound like mission impossible? I dare say it does not have to be with the right tools and assistance from a certified diabetes care and education specialist. So just to review with you, the ADA has a somewhat complex looking algorithm for initiation and titration of insulin. So I have for you here a few snapshots of the most important points that you can utilize to initiate and adjust your insulin remotely and to explain to your patient how to do self-titration at home. So if you're adding a basal insulin, whether it be a 24-hour or an NPH, you can simply start with 10 units a day. Most adults can handle that. However, if you do have a patient with a higher BMI, it might be a better idea to utilize a weight-based formulation so that the patient sees some benefit once they start the insulin. The worst thing to happen would be to start somebody on insulin and they see no response and they stop it too quickly. So once you've got your patient started, you can simply increase the dose by 2 units every 3 days. And you want to educate your patient on this process. You want to provide them with a fasting glycemic target that they're looking to reach by making these adjustments simply 2 units every 3 days. And then I want you to think beyond the basal. If the A1C continues to be above target, despite adequate titration, or if they have achieved their fasting glycemic target already, or if the weight-based dose has reached 0.5 kilograms. So it's really important that we set a limit with our patient. We don't want them to be just escalating the insulin dose with no end in sight. Typically, when a patient is reaching 40 to 50 units of basal insulin, we want to start thinking about adding other things. So we call this basal plus. If we need to add a prandial insulin at one meal in addition to the basal insulin, we can simply just pick one meal a day to get them started, maybe the biggest meal of the day. And it's fairly safe to initiate just 4 units at that one meal and then educate our patients to increase the dose by just 1 or 2 units a couple of times a week. So nothing too complicated. Again, giving them some glycemic targets around their prandial values so they know when to stop. And if there's hypoglycemia, we can pull back on the dose by about 10%. If a patient was started on once daily NPH, and now you need to add another dose of NPH to provide broader coverage throughout the 24-hour day, you can take that dose, 80% of it, and administer 2/3 before breakfast and 1/3 before dinner. And then, again, just simply titrate by a couple of units a couple of times a week. So providing patients with these little bits of information will help them to keep moving and gaining progress. So what if we need to titrate the insulin again if the A1C remains above target? If you're going to add additional insulin at meals, you can simply add it in the same fashion that you started at your first meal, 4 units, titrating by a couple of units a couple of times a week. If your patient were on NPH and you wanted to add prandial insulin to that regimen, you could do the same thing, 4 units, however, at breakfast, and they would need to mix the NPH in a syringe from the 2 different types of insulins, and then add the 4 units also to dinner and move that bedtime dose of NPH to dinner time so they are mixing again the 2 different insulins in one syringe. Or you could consider pre-mixed insulin twice a day, which would be administered just before breakfast and just before dinner. And again, with all of these, just titrating the dose by a couple of units a couple of times a week to meet the targets that you set with the patient. So this is a great opportunity to utilize shared decision making. There's a lot of different options here. We know basal bolus is the most physiologic, but perhaps the most burdensome for our patients with 4 injections a day. When we think about that middle box, mixing 2 different insulins, can your patient do this? Do they have the capability and the dexterity to mix from 2 different types of insulin? And with the pre-mixed, which may be the simplest answer, it is not as physiologic and it allows for less personalization of the dose because as you adjust the dose, you're adjusting both components whether you need to or not. So engage your patient in which process is going to be best for them because we know patients who are invested in their treatment plan are much more likely to stick with it. So important with all insulin adjustments is to avoid inertia and be bold for our patients and don't let a national pandemic stop your patient's personal progress. In fact, many people now have a little more time on their hands. A lot of people are working remotely. They don't have that hour commute to work back and forth each day, so they may have a little more time to focus on their diabetes health. So open the lines of communication. Let your patients know you're available and continue to make adjustments. Teach your patients to be self-directed and give them targets and limits for their adjustment. Embrace technology whenever you can. We're going to look at some apps that can assist patients in self-management and education at home, as well as assist you, the provider, in the office to streamline all the data that may be coming at you remotely. And 100% call in the reinforcements. Contact a certified diabetes care and education specialist in your area. So there are many apps that can assist patients with insulin adjustment, and it's important to use ones that are peer-reviewed and perhaps even FDA approved. So what you're looking at on your screen now is an example of an app that's FDA approved for basal insulin titration only. It's called Insulin. It does require a prescription from you to the patient, and then the healthcare provider still makes the decisions as far as the insulin adjustment and titration schedule. So the visual you can see on the left, you see a series of glucose ranges, and then just to the right of that, an aligning adjustment increase or decrease in the basal insulin depending on the glucose value. To the far right, you see some information that's being pushed to the patient through the app. It's looking at a series of fasting values over 3 days and recommending a 1-unit insulin adjustment in the basal insulin for the patient. So the patient's receiving this information routinely. They can see the treatment regimen that you have prescribed, and you do not have to engage in communication back and forth with the patient on a daily basis. You can view this data remotely or once a week or every couple of weeks to see your patient's progress, but they are constantly getting feedback from the app. Additionally, there are over 46 apps that can help assist patient with insulin adjustments and calculating doses. Many of these apps also have the ability to provide real-time coaching and diabetes education. So you can really extend the diabetes educator into the home with use of some of these apps that provide ongoing education and support. So just an example that I've given you here. On the far left, you see the patient's glucose is displayed, and the app is encouraging the patient to join in a weekly exercise challenge. They get rewarded if they achieve their exercise goals, for example. In the middle, it's offering them some ideas for a healthy breakfast option, asking them if they want to participate in a learning module on carbohydrate counting. And then finally, on your far right, you see where the app is giving the patient back some feedback regarding an elevated glucose and asking them, did maybe you just eat before you checked your blood sugar? Did you wash your hands? Maybe this is from glucose production of the liver overnight, and maybe you need to contact your provider to discuss these high numbers if they're occurring routinely. So a great opportunity to provide continued support and education beyond the reach of the office. And what about our glucose meters? How about getting more out of them than just looking at one digit one time? There are over half a dozen glucose meters that connect with an app that can push data via cloud-based portal to your email, your EMR, and so forth. So the example that I've provided for you here on the top, you see where this snippet from the portal is comparing a current 2-week average with the previous 14-day average. So you and the patient both get to see the progress that's being achieved. It also provides you with information regarding time and range and number of glucose checks in a given period of time. On the bottom, the patient and you have an opportunity to look at readings, average readings over time, over the course of a year. You can look at progress and perhaps better identify times of the year that might be more problematic for some patients. And then you can get your traditional logbook, as you see on the top graphic, minus the coffee and blood stains that we're used to seeing. And you can see here where the patient has the opportunity to indicate is a glucose value before a meal, as indicated by the full apple, or after the meal, as indicated by the apple core. In this situation, the patient did enter their insulin doses, so you get to see that. they have an opportunity to put in things like exercise or illness or other information that may be helpful to you as the provider to know when you're reviewing their glucose data. And then on the bottom, you see where the app is able to identify some patterns. So this can be really powerful for patients, and it helps you and the patient to kind of draw your attention away from those outlier glucose values and focus more on things that are occurring more commonly and target areas in need of adjustments with your insulin more readily. For patients using a pen, a nice option is a smart pen called the InPen. This is a Bluetooth connected device that uses disposable cartridges of rapid-acting insulin. The pen connects to an app, and the app records the exact time and the precise dose of the insulin that's administered. There are several meters that can connect with the app via Bluetooth, and it imports those glucose values right into the report, in addition to being able to incorporate values from a CGM. So all the data is compiled into one comprehensive report. And how often do you have a patient in your office and you may be reviewing a meter or a glucose log, and you're asking them about their insulin administration, or maybe did they forget an injection related to a significant variation in glucose, and they cannot recall? Well, this takes all of that guessing and confusion out of it, because you see exactly when insulin doses were administered or perhaps even missed. So let's take it a step further. What about continuous glucose monitoring to help our patients? There are currently 4 devices on the market which can be used very simply or for more advanced self-management. They allow for remote sharing of data between you and the patient. They allow the patient to see not only what is their glucose at that moment, but where is it headed and where is it going. It has the ability to alert patients to hypoglycemia, so there are no severe events. So certainly when a patient has all of this data at their fingertips, it's empowering, and they feel a little more confident in diabetes self-management and adjustment. So I'm going to share with you just a few examples of how using CGM may help you to make different decisions than you otherwise may have without knowing all the data. So first, we have a patient who reports that fasting values are generally in range, 100 to 160 area, yet the A1C remains above goal at 8%. The patient's not interested in checking more frequently, but they were willing to wear a continuous glucose monitor. So what you're looking at here, each colored line represents a different day of the week as noted on the bottom. And this is a 24-hour grid. You see the timestamp along the bottom, and it's compiling all the days of the week together comprehensively. So you can see that the overnight values are fairly steady and generally in a good range. But what's been revealed is this significant glycemic variability that we're noting after meals that was otherwise unrealized. So this is a great opportunity to add a prandial dose of insulin to help improve that patient's A1C. And you could just start with that 1 meal a day and go from there. So what do you do with all this data if this is not something you're used to looking at routinely? Well, fortunately, there is a standardized report across all of the CGMs called an ambulatory glucose profile. And this report will give you averages and information on the data that has been compiled. So for example, here you see on this report an average glucose of 173, a GMI, which would correlate with an A1C if the pattern continued over the next 90 days. And then you see a colored bar indicating time and range. So what does that mean? Is 47% time and target range good, bad, indifferent? And we're looking at time and range at 70 to 180. Well, the reports give you the information that you're looking for to your left. So the target for time and range is 70% or greater. This particular patient is 47% time and range and 43% above goal. So it helps us to identify that there's some work to be done here. Let's look at another example. Here's a situation where a patient called the office reporting fasting hyperglycemia. And if all you had were those fasting values, you might be inclined to raise the basal insulin dose. However, the CGM reveals that the values during the day are generally in range and, in fact, sometimes approaching low blood sugar. Clearly, you see the overnight hyperglycemia between 3 and 6 a.m. but just escalating the basal dose here might result in hypoglycemia during the day. So this might be a good opportunity to use an NPH prior to bed to target that overnight spike, yet not cause low blood sugar during the day. This is just another example looking at a single day at a time of the glucose graph. And in this situation, the basal insulin was escalated due to an elevation of A1C. However, what ultimately happened was fasting hypoglycemia, yet glucose excursions and hyperglycemia persist during the rest of the day. So seeing this data and what's happening behind the scenes, you may choose to actually pull back on the basal insulin and in fact add some prandial insulin later in the day. Another example of where the fasting target is essentially achieved. You can see steady glucose values, fairly steady overnight, mostly in range, but then once the patient starts to eat, significant glycemic excursions during the day. So the dotted line representing the average glucose during the day is above goal, and the vertical bars representing the glycemic variability are very high and very low. So this is an opportunity to engage a diabetes care and education specialist, perhaps consider medical nutrition therapy and an appointment with a nutritionist to find out what's happening with these meals during the day that's causing such significant glucose excursions. And then I just wanted to share this with you a little bit to just think beyond the A1C. So certainly A1C has been our gold standard for a long time, but we know over the years the data has showed us that time and range is so very important. So in this particular example, you can see glucose values that are high, that are low, that are everywhere in between. We call this the roller coaster ride. And we want to think about glycemic variability. We know it impacts endothelial dysfunction, which can ultimately lead to the development of both microvascular and macrovascular complications. So certainly the ability to use CGM is going to help our patients stay in range more frequently and avoid some of those detrimental complications that can be associated not only with elevated A1C, but with glycemic variability. So with the use of technology, we often have an opportunity for greater patient empowerment. We want to make sure our patients are informed on their personal glycemic targets. We know with diabetes there's no cookie cutter formulation and no exact method for every patient, but it's important that they're aware of what their targets are. So listed for you here are the ADA standard targets for fasting, pre-meal, and post-meal glucose ranges, but you want to absolutely individualize this for your patient. If your patient's unable to use CGM, consider paired glucose monitoring. Here's an opportunity where you can ask a patient to check their glucose before their meal, 2 hours after the start of the meal. They don't have to do every meal every day. Perhaps they do breakfast 2 or 3 days in a row, then lunch 2 or 3 days in a row, and so forth. And by the end of a week or so, you have a really good insight into what's happening in the 24-hour day without having them check their glucose more than twice a day. Using technology whenever possible is certainly helpful and going to give you a lot of insight into what's happening, and considering those apps that provide coaching, extending the reach of the diabetes educator beyond the office. Certainly we have to think about safety. We know insulin can cause hypoglycemia. So if you have a patient new to insulin, have they ever had a low blood sugar? Do they know what that feels like? Talking to them about that at every visit is vitally important. Talking about events, symptoms, what's the appropriate treatment, and do they actually have any of that stuff in the home with them? For patients using pens, just some tips about priming the pen. Each patient should do a 2-unit prime before delivering their dose. What would happen if you started your patient on that 4-unit dose before a meal and they never prime their pen? Potentially they might only be getting 50% of the prescribed treatment plan. Can they see the number on the pen? There are small magnifying devices that can be clipped onto the pen so that they can see the numbers better, or we could educate them to listen to the clicks on the pen if they're unable to see the pen's numbers, so that we know that they're getting the right dose. And always asking them to self-demonstrate. As mentioned previously by the previous speaker, we have a great opportunity here to see into the patient's home. They are at home with their insulin, with all their devices. have them self-demonstrate an injection. Have them show you the number on the pen that they've dialed to. I had a patient once who, for whatever reason, thought that 3 was equivalent to 30 units. So clearly there was a gap in communication and education there, but we never want to assume. In particular, if patients are not meeting their treatment targets, go back to the basics and do some self-demonstration. If patients are using syringes, there are also devices to assist them in seeing the lines and numbers. There's a magnifier that can be clipped onto the barrel of the syringe, and there's also a magnet that can be hold a vial of insulin and adhered to the refrigerator. So now your patient has 2 hands to manipulate the syringe rather than fumbling with the 2 different things. And I cannot underscore enough the importance of site rotation. If patients, we teach them to inject in the abdomen initially, and then we never go back to that. They think that's the only place they can do their injections. Over time, the buildup of scar tissue or lipohypertrophy significantly impacts glycemic variability and makes the absorption of the insulin so unpredictable. So each appointment, go back to revisiting not only hypoglycemia, injection technique, but also injection sites. So call in the reinforcements. Diabetes care and education specialists are here to help you. You can go to the association website, diabeteseducator.org, to search for diabetes educator in your area. Sadly, only 5% of Medicare patients who have the benefit for diabetes education utilize it, and under 7% of patients with private insurance receive diabetes education within the first year of diagnosis. The good news is that recently, CMS, as of August 12th, approved accredited and recognized diabetes education programs to administer and bill for education via telehealth. So this not only allows the opportunity for registered dietitians to perform diabetes education and bill for it remotely or via telehealth, but also nurses and pharmacists who are working at these accredited programs. So there's a lot more people now available to help our patients remotely. So what are the benefits of diabetes education? There are many evidence-based driven results. Some of them are listed for you here. They include things such as lowering A1C, reducing mortality, reducing hospital admissions, lowering hypoglycemia, improving quality of life. So the 2020 consensus statement for diabetes education posed this question. If you had a pill that could do all of this, wouldn't you prescribe it? So I challenge you to think of it that way. Refer your patients to a diabetes care and education specialist. There are 4 times that are considered critical for referral to diabetes education, and they include at diagnosis of diabetes, annually, or when not meeting treatment targets, when complicating factors occur, such as the development of retinopathy or neuropathy, and when transitions in life or care occur, such as discharge from a hospital or a change in living situation. So what can a diabetes care and education specialist do for you remotely? We can help to navigate the available apps and find one that's good for you, one that's been peer reviewed and FDA approved, one that you and your patient are satisfied with. We can assess patients for use of CGM and determine the right choice. We can assist your patient in connecting with you remotely in regards to data sharing. And a diabetes educator can conduct a deep dive or forensic examination of the data to help your patients realize cause and effect of glycemic variability, to guide your patients to establish self-determined goals and action plans, and to empower your patients to be self-directed during COVID and beyond. And this is just the tip of the iceberg. I leave you with some very powerful quotes regarding the importance of education. So I hope that during this presentation you were able to learn a few things, a few pearls and tools about remote monitoring and continued access to your patients remotely and virtually, and vice versa, your patient's ability to communicate with you, to keep the progress going, and to keep moving the needle to improve their overall diabetes health. And I thank you for your time, and I'm happy to field any questions.
Thank you so much, Eileen, for that excellent presentation. And we're going to encourage you to type any questions you have into the Q&A box. And there were some questions that came in during the presentation. You'd refer to exercise. Nicole, maybe you want to just, if you're able to summarize some of the questions on exercise and meals.
Yeah, so there was a question that came out about how to motivate people to exercise. And one thing that has been mentioned throughout the series is potentially walking after meals. And this is sort of based on a study where they actually looked at if you walk for 30 to 40 minutes a day versus 10 to 15 minutes after each meal and use CGM to evaluate overall glycemic control. They actually found that you had better glycemic control by walking for 10 to 15 minutes after meals. Now, we don't want to discourage people from 30 to 50 minutes of daily walking, but sometimes those small bits are a little bit more manageable in people's busy schedules. And so as we heard from one of our participants, they've already used that technique and they're finding good success in their clinical practice, which is something I've also found.
Thank you. And then any other questions that came in, anyone wants to bring up?
Thank you, Nick. I just wanted to share one thing that I learned from a social worker who was an expert in motivational interviewing. He used a rating scale that you can use for how important something is or how motivated you feel for something, and people would use the rating scale. And what shocked me was the question that you ask after that is, why didn't you rate this one lower? It's a great idea, it's a great technique, and the answer to that is the foot in the door for what's the motivation that they have for choosing those measures. So it's a great idea, and I just wanted to share it with everybody. Thank you.
Nick, one more comment. I really like the discussion on how to initiate basal insulin because I think that's something that a lot of people struggle with, choosing the right initial insulin dose to reduce risk of hypoglycemia and but also see effect from the basal insulin so people are motivated to stay on it. And so, in someone that's at high risk for hypoglycemia that has renal dysfunction, it's very appropriate to start at 10 units or 0.1 unit per kilogram. But we see so many people with morbid obesity, with very high BMIs. And so starting at a higher basal insulin dose, potentially 0.3 units per kilogram, would be a safe dose, but also potentially allow the people to see more benefit.
Question is, what are the recommendations for nursing home residents with diabetes during COVID-19? And the ECHO Institute is partnering with the Agency for Healthcare Research and Quality to build a learning network to improve quality improvement in nursing homes throughout the country, targeting 15,000 nursing homes. So if you are interested in partnering with the ECHO Institute, please go ahead and click on that link there. And many hubs around the country are working to support this initiative. People in nursing homes are a vulnerable population. Half of adults with US have either diabetes or prediabetes, and 45% of COVID-19 deaths are occurring in nursing homes and assisted living facilities. And the American Diabetes Association, and we can type in the chat box the link for this physician's statement, has some guidance that was published in 2016 in Diabetes Care on management of diabetes and long-term care, and noting that this population is heterogeneous and comorbidities are variable. And so it's critical to establish personalized goals and treatment plans. So for example, an A1C target of 7%, it may not be a reasonable individualized goal. And particularly paying attention to hypoglycemia, simplified regimen plans, and also to diets. And so I recommend, for those of you interested, can further reference more of the guidelines that are published by the American Diabetes Association.